Welcome to ETMC TV and this physician consultation with Frank Navetta, MD, board-certified and fellowship-trained interventional cardiologist. Dr. Navetta will discuss cardiac catheterization procedures. Thank you for choosing ETMC TV.
People come to us for a variety of different reasons, from problems with chest pain, from problems with congestive heart failure, rhythm disturbances, and then based on their particular set of problems, their history, their physical examination, and perhaps testing that they've had along the way, then they may be referred for a catheterization procedure. The cath lab is a pretty amazing place. What happens there is tailored to what your particular problem is, but it's a huge list of different diagnostic and therapeutic procedures and maneuvers that can take place. If you look at the diagnostic side of the cath lab, what takes place there is right and left heart catheterization and various different arteriograms or angiograms which essentially outline the arterial blood flow anywhere from the coronaries to the aorta, the main blood vessel that leaves the heart, to the carotid arteries in the neck, to the upper extremity arteries, to the abdominal aorta, to the renal arteries, and then even down to the lower extremities, where we have the expertise as cardiologists to not only take those pictures, but also then to do interventional procedures on any set of those arteries, pretty much from the heart, obviously from the head down to the toes. That's just one aspect of it. Other aspects that take place in the cath lab are more hemodynamic measurements. We can measure pressures inside all the different chambers of the heart. That's important sometimes in patients who have valvular heart disease to try to determine whether they're at a point that they need valve replacement. We can measure pressures on the right side of the heart in patients who have lung disease and pulmonary hypertension. And holes can exist in the heart, and we can diagnose those by pressure measurements. We can actually do ultrasound from inside the artery to determine the severity of a blockage or what the composition of the plaque is. That may be important in the treatment of a stent or a different type of device to open up that artery. We can even perform ultrasound within the heart to look at some of these abnormalities with valves or with holes in the chambers. If a patient comes in and is having chest pain, they've got a pretty typical history. They have maybe a stress test beforehand that shows that the front wall of their heart is deprived of blood flow. If you saw a high-grade blockage in that artery and it looked like something that was appropriate to fix with a balloon or a stent, then you have all this background information at that point to fix it. Or perhaps we have to call a surgeon up to say, let's consult about this particular patient, come take a look at these films that we've got and see what you think about cardiac surgery. To do a standard heart catheterization generally takes me less than 10 minutes from the beginning to the end. So it doesn't take very long, doesn't hurt very much, and it's very safe. The procedure itself is done with a good dose of local anesthetic above the access point, whether that's in the femoral artery or in the wrist, to kind of numb that area, much in the same way as if you were having dental work done. But patients are awake during the procedure. We oftentimes talk to them, especially when we're doing interventions. The extent of the invasiveness of the procedure involves a hole in the skin that's probably this big, maybe 1/8 of an inch, and that's made with a small scalpel tip, and that's it. If we use a femoral approach, and it's strictly a diagnostic procedure, our tubes are very small. The level of anticoagulant that we use is almost non-existent, and when those tubes come out, the blood vessel can heal within a couple of hours. In a couple of days of bed rest, they're back to normal. And the bed rest is a function of whether it's a diagnostic procedure or whether it's a procedure where they're having a stent, they need more blood thinners, because sometimes the tube that we have to access the artery with is bigger. If we're doing a radial artery approach, there's essentially no bed rest because the patient has not had his leg accessed so they can walk, and typically what they do is they get a little pressure thing. It's probably about this big that sits over the radial artery. It's a little pressure device, and that'll stay on there for an hour or so, and then it comes off, and they can walk out of the hospital. But this is really a minor procedure. There are some risks. Those risks are very slim, and we tell patients that. But the other side of the coin is sometimes there's risk to not doing anything, which is you don't know what the problem is. And we would rather see you at 2 o'clock in the afternoon than 2 o'clock in the morning.
Dr. Frank Navetta is an interventional cardiologist with Tyler Cardiovascular Consultants and the ETMC Cardiovascular Institute. To make an appointment, please call 903-595-5514.
Well, I grew up in New York, and I went to med school at New York Medical College. From there, I did my internship, residency, and cardiology fellowship at Duke University Medical Center in Durham, North Carolina, completing that in the summer of 1990, and then I started here in July of 1990.